Thanks to the chairman and also to SAGES and all of you for your kind attention. So I'm going to be talking about when should I operate? And yeah, so decisions, right? So we could do it now. Is it 72 hours? Less than 5 days? 7 days? 4 to 6 weeks? And what I would propose is that it actually, or never, and what I would propose is really the selection and timing of definitive treatment really depends on two factors. One of them is the severity of the disease, and one of them is the amount of comorbid illness and medical risk in your patient. So in the low-risk patient, I think we saw this before from our prior speaker, with very severe disease, operation as soon as possible, but you've got to resuscitate them first. But what about the patient with a little less severe disease, and what information can we glean? Despite a number of papers in the pre-lap chole era suggesting that early operation was a good thing, the practice patterns in both the United States and the United Kingdom have a substantial number of people who are observed, given antibiotics, discharged home for delayed operation. This has been looked at several times. The most recent Cochrane review says that there's no difference between those two groups. One of the problems with the Cochrane review from 2012 is that due to their extreme vetting, we're only left with 5 studies with about 245 patients in each arm. So looking at the important things such as major bile duct injury and mortality, which are rare, are going to be subject to type 2 error. So we have a more recent meta-analysis of 1,500 patients, which is a little bit better, which shows that early cholecystectomy has less wound infection, decreased hospital stay, less work days lost, a slightly longer operating room time, but no real difference in some of the big things that we're concerned about, which is mortality, duct injury, conversions, and complications. But this study, too, is probably underpowered. So what do? Let's go for the big data, shall we? This is from the Swedish Registry study, looking at several things. This is intraoperative events here, postoperative adverse events, and conversion rate in admission day 1 to greater than or equal to 5 days. And what you see is that there's a substantial increase in, especially in conversion rate here. Some intraoperative events are lower substantially than here, as are some of the post-op adverse events. Now let's look at it a little more closely. And I know it's a busy slide, but it was the only way I could try and do it. So, but intraoperative adverse events, really, there's a statistical significance both in multivariate and univariate analysis of an advantage with early cholecystectomy. No change in intraoperative bleeding. For some reason, if you operated on the first day, your bile duct injury was less. Postoperative adverse events, substantial difference in just about everything. Whoops, sorry. In just about everything here. Mortality, no real big differences that we can see, but some differences in 90-day mortality from early operation. The important thing I think to take away here also, though, is that the Swedish are early adopters of doing early cholecystectomy, and the majority of the patients that were done were actually done in the first day or 2 after they've been resuscitated. And the number that actually were, the number of patients here was only 5% who were the people who were subjected to the trials and tribulations of 4 to 6 weeks. So what are we going to do with that? So our nice neighbors to the north, the Canadians, decided to do propensity score analysis and trying to get matched groups. Their major their major goal was to look at major bile duct injury, and then they had a pooled morbidity of major bile injury or death, and then mortality. And these are the secondary goals. So what do we see? Bile duct injury in the matched groups, advantage early cholecystectomy. Also for their pooled morbidities. But again, no big changes in mortality, cases completed open, or conversions in the matched groups. But certainly early operation is not worse, and we're not, quote, letting things cool down for a more favorable outcome. Well, what about the 72 hours? This is when there's a change between acute cholecystitis as an inflammatory condition and as a condition where there's a lot more infection and chronic changes and fibrosis. So this is a randomized controlled trial. It is small from Switzerland, but it is randomized, and so that takes away some of that bias of only observing the patients with more morbid disease. So what do we see? The overall morbidity, whoops, I'm not doing a very good job here, there we go. So early laparoscopic cholecystectomy has advantages, especially with respect to unplanned readmissions, which is really much more common in patients who have been randomized to 4 to 6 weeks. The total antibiotic duration is less, the total hospital length of stay is less, and actually cost is lower. Operating room time, cholangiography, et cetera, and most all of these other things other than postoperative length of stay, postoperative length of stay is really not much different. But there is a significant amount of morbidity from the patients who bounce back to the hospital once or twice. The other interesting thing is that what they found is that the patients who were subjected to observation had a much higher incidence of chronic cholecystitis as opposed to acute cholecystitis. And I don't know about you, but I'd rather see acute cholecystitis than chronic, as graded pathologically. So, in my view, I think that 4 to 6 weeks is just like our government, which is just kicking the can down the road, and you're going to get pain later rather than now. What about high-risk patients? Antibiotics alone, I think in less severe cases. There's cholecystostomy, which I'm not going to mention because we're going to have a talk on that in a minute. And then endoscopic approach, which I'll just cover for just a second because I think it's interesting. This is, of course, from a gastroenterologist, a friend of mine, showing that the least invasive thing is to actually poke holes in different things and put stents across as opposed to an operation, which I think we could talk about. This is a patient with metastatic pancreatic cancer. The porta's a mess, who underwent this stent placement. And this is the pus that came out of the gallbladder. This is somebody who had a stenting of the common bile duct and then got acute cholecystitis. This is somebody who has about every comorbidity you'd ever want or not want, who had stone disease where you can not only drain the gallbladder, but also you can remove some of the stones. Occasionally we're stuck, patients really sick. Lots of comorbid situations, but we have to consider a cholecystectomy. And here's a case here. You'll note that the patient has air around the gallbladder, emphysematous cholecystitis. You'll also notice this little piece of hardware that the patient has, which is right up here. which happens to be the LVAD. Thank you very much. This patient actually was about as good as they're going to get. With cardiology, their blessing actually underwent a laparoscopic cholecystectomy successfully. Sepsis was controlled. Patient had a lot of problems with their heart and succumbed about 2 or 3 months later because they were tired. But sometimes you just have to take the bull by the horns. So this is the algorithm from up to date. You saw a similar type of situation here where, again, acute cholecystitis, so low-risk patients who are especially deteriorating get emergently clinical improvement. We should probably operate early, and within 72 hours would probably be nice if you can do it, but sometimes they'll present later. High-risk patients, they may be discharged and maybe we'll just see what happens. Clinical deterioration, and we'll hear about a lot more about that from our next speaker. So, if I have one message, it's the message that John Keating gave to his pupils, which is Carpe Diem, seize the day. Thank you.